And we're back for our third and final episode of our trilogy on anemias. Today we're finishing up with macrocytic anemia. So please, if you haven't already watched, we have a video on microcytic anemia, normocytic anemia, and now again we are finishing with macrocytic. So please check those out. We have a nice trilogy for you. But again, we are finishing today with macrocytic. We've got a pretty cool episode. We're going to be doing 3 cases. You have to try and solve each case as we go along with some questions, some answers, and a pretty fun discussion.
Yep, absolutely.
All right, so let's just jump right into it. Macrocytic anemia. Here we go. Case 1, we have a 62-year-old male, presents with fatigue, numbness in his hands and feet, and difficulty walking. His HPI, the patient reports progressive fatigue over the last few months, making it difficult to complete daily activities. He also has experienced numbness and tingling in his hands and feet, which he describes as pins and needles. And he also has occasional difficulty maintaining his balance, particularly when walking on uneven surfaces. He denies alcohol use or recent changes in diet, but mentions a history of gastritis treated with over-the-counter antacids. He also noticed some forgetfulness and mild mood changes, which he reports as stress-related. For our physical exam, his vitals, blood pressure is 135/85, heart rate is 80, respirations is 16, and his temp is 38.6 Celsius. For his neuro exam, there is decreased proprioception and vibration sense in both feet. He exhibits a wide-based gait, and there is mild weakness in bilateral lower extremities. His skin is pale with no jaundice, and for his oral exam, there is mild glossitis with a smooth tongue. We do a lab panel. We get some findings back. They are as follows: hemoglobin of 9, MCV 115, reticulocyte index less than 2%, peripheral blood smear is hypersegmented neutrophils, vitamin B12 is low, methylmalonic acid MMA is elevated, homocysteine is elevated. So we have some new lab findings here, Zach, that we didn't quite discuss yet in micro or normocytic anemia. Of course, it's pertinent for macrocytic. So in particular, the methylmalonic acid and the homocysteine, what are those labs, and can you just describe what they're testing and why is it pertinent for this patient?
So when we talk about looking at these two, methylmalonyl-CoA and homocysteine, these are basically molecules that are involved in a couple different biochemical pathways. We probably talked about this back in biochemistry, but simply, methylmalonyl-CoA is supposed to be converted into succinyl-CoA, and that is heavily dependent upon the presence of B12. Not as much in folate, all right? So when a patient has a B12 deficiency, you won't be able to convert that methylmalonyl-CoA into succinyl-CoA. So as a result, the methylmalonyl-CoA will go up in B12 deficiency, but it won't really be affected in folate deficiency. Both folate and B12 are absolutely necessary, though, to convert homocysteine into methionine. And so if a patient has a deficiency in folate or a deficiency in B12, they won't be able to convert that homocysteine into methionine. And so as a result, homocysteine levels tend to go up. So the benefit of these, really when it comes to it, is ordering these when a patient has borderline low, normal range, folate and B12, and then look at these to kind of have an understanding of what's going on. And if the levels are elevated of MMA, you should really be thinking about B12. And if the levels are normal of MMA, you should maybe start considering folate deficiency, because homocysteine is going to be elevated in both of them. So that'd be kind of the pertinence to that.
So up to this point with our discussion throughout anemias, we've kind of concluded through the lab data that MCV is pretty important for determining where we're at as far as micro, normo, or macro. Micro being less than 80, normal being 80 to 100, and then macro being greater than 100.
Yep.
So in this patient, we can pretty much conclude then again that being that the MCV is greater than 100, we have a macro.
Absolutely. So if you have a patient who has hemoglobin less than 13 as a male, less than 12 for a female, I know we've said that so many times, you got anemia, check the MCV just as you said, greater than 100, boom, you got a macrocytic anemia.
Hey, review is always important. So
Absolutely,
let's just repetition, right?
Yep.
All right. So any other way you would approach this anemia in this patient?
Yeah, so I think the other component here is that since we've really determined that this is a macrocytic anemia based upon the MCV, the next component here is trying to determine which type of macrocytic anemia it is. Is it megaloblastic or non-megaloblastic? And the best way of being able to determine that is to get a peripheral blood smear. And that's really the only way that I could do that.
And we have the hypersegmented neutrophils. Tell us a little bit about that.
So whenever a patient has a B12 deficiency or a folate deficiency, those are super critical to DNA synthesis. And so they help with maturation of the DNA. And so in patients who have this folate deficiency or B12 deficiency, they don't have that adequate DNA synthesis. And so the nucleus doesn't completely mature. And unfortunately, whenever cells try to mature, they try to like really condense their nucleus a lot more. Unfortunately, in patients who have what's called your neutrophils, they just don't completely get to the point where they mature. And so they have so many different lobes. So neutrophils normally have a couple different lobes on them within their nucleus. But if you see greater than 5 or more nuclei, kind of like multilobated nuclei, you should really be concerned for hypersegmented neutrophils, and that highly suggests megaloblastic anemia, which is the B12 and the folate deficiency. If I didn't see that, then I may think more of the non-megaloblastic.
That was my next question. Thank you. You're already ahead of the game.
I got you, boy.
Okay. So with the elevated MMA, elevated homocysteine levels, what distinguishes B12 deficiency from folate deficiency?
I think it's a combination of things. And so you kind of hit the nail on the head that, again, in this scenario, the B12 level was low. I happened to get that methylmalonyl-CoA. I happened to get the homocysteine levels as well. And again, kind of going back to that initial question, what's the pertinence of these? If it's an elevated MMA, elevated homocysteine, that only really suggests B12 deficiency. Now, the other thing that really is important for B12 deficiency that is kind of different from folate deficiency is neurological symptoms. And that's kind of something that I see here. And so that really would make me be a little bit more concerned for B12 deficiency.
So what about the neurological symptoms are so concerning, being that especially we have that wide-based gait, there's decreased proprioception, vibration sense. What does all this mean?
Yeah, so whenever a patient has B12 deficiency, what happens is again, it goes back to the methylmalonyl-CoA, and that's why it's so different, is that B12 deficiency has, again, an effect on the methylmalonyl to succinyl-CoA pathway. So methylmalonyl-CoA levels build up, and they tend to build up in the neurons of your spinal cord and even parts of other, peripheral nerves. But what happens is the methylmalonyl levels go up, they cause demyelination of axons. And that tends to affect the dorsal column. So that's why they would get the loss of proprioception and maybe vibration sense. And sometimes you can even say with a positive Romberg sign. So I would even do a Romberg test to see if they have any abnormalities there. The other thing is that it hits the spinocerebellar tract. And the spinocerebellar tract causes ataxia. So that may be causing a little bit of the imbalance and stuff when they're walking. The next test is I would also look for the corticospinal tracts. So the corticospinal tracts can also be hit. It's probably the last one to be hit, but that would cause like a spastic type of paresis. And so I'd want to watch out for any kind of evidence of that. I don't really see any evidence of like weakness. That's usually the last type of like tract to get hit.
I mean, he has very mild weakness, but we're not quite there at like where you would probably notice it.
Yeah, I don't see any like evidence of like true spastic paresis in this patient, but I do have a concern for the vibratory sense, the proprioception, and the ataxia. And the other thing is like the pins and needles, that could be peripheral neuropathy.
Okay.
And so there could be some demyelination of some of the peripheral nerves causing some of the peripheral neuropathy to come about. And then even neuropsychiatric disturbances. So B12 deficiency also can cause like patients to appear delirious. And so maybe some of the mild mood changes and forgetfulness and having these neuropsychiatric behavior changes makes me also think about B12 deficiency. The reason why it's really important to identify this is that if I have a patient who, they come in, I do some blood work, I find that they have macrocytic anemia, and I'm kind of like working my labs up, and I'm like, oh, okay, could be B12, could be folate. And I just like start them empirically on just like folate for whatever reason. It'll mask the symptoms of their overall anemia. It may improve their anemia, but the neurological symptoms can continue to worsen. And once those neurons demyelinate, it's hard for them to be able to recover. So it's really critical that if you notice neurological symptoms, you have to get on these patients and treat them quickly with IM-B12 to try to hopefully reverse some of the damage and not have the long-term damage. It might take a couple weeks or months, but it'll come back.
Prior to my next question, again, trying to really figure out and elucidate the cause of the B12 deficiency. Before getting into that, I did note on the oral exam, there was mild glossitis with a smooth tongue. What does that indicate?
So that can actually be, again, with the DNA. So when you talk about B12 deficiency, if you have less B12, you don't allow for as much replication to occur. And so sometimes they can have changes. So this is pretty common. Any kind of glossitis or angular cheilitis is kind of common in scenarios of iron deficiency anemia, as well as in patients with vitamin B12 deficiency. So glossitis definitely should bring about the concern potentially of an anemia in this scenario.
And that could get you really thinking differential-wise on your B12.
Yeah. The neurological symptoms are definitely the most concerning, but glossitis and angular cheilitis those are definitely some clinical manifestations that you can see in B12 deficiency.
So would you do any other steps in order to really elucidate the cause of the patient's B12 deficiency?
Yeah, because you can give them B12, but it's always important to figure out why, so that they don't have to be on B12. Or also, I think it's important to know what kind of B12 you should get them. The reason why is we'll talk about it later with folate deficiency. With folate deficiency, you can give them oral. It doesn't really matter, even if they have a malabsorptive disorder. But for me, I want to know, does the patient have a poor intake, an increased demand? Are they not absorbing the B12? Because that's really, really critical to how I'll treat them. And so there used to be a test called the Schilling test. We don't do it as much anymore. It's an older test, so maybe some of the old heads who are practicing, they use it. But you give them a dose of B12, like a radio-labeled dose of B12, and you look to see how much of that B12 gets in the urine. If they have a normal amount in the urine, it's probably they're not taking in enough, or there's probably a demand problem. They have a high demand. So usually if you see this in strict vegans, you may even see it in other patients who have like abnormalities where they're pregnant. So pregnancy can also cause this as well. The other scenario is if you have, you give them the radio-labeled B12 and the B12 level is low in the urine. That means that you're probably not absorbing it. And so that would be an absorptive issue. And so then what they do is they say, okay, if it's an absorptive issue, could it be at the stomach? Could it be in the small intestine? Could it be the pancreas? And so then you have to kind of further go on through your testing. So then you have to give them IM B12. Because in patients who have like pernicious anemia, they may be making antibodies against the cells that help to absorb B12, because our stomach makes something called intrinsic factor, which binds the B12, which is needed for absorption. So if patients have pernicious anemia, that would be a site. So you give them IM B12, you bypass the whole oral route and it'll improve. Another thing is that if a pancreas isn't working, pancreas is supposed to help in playing a role in allowing for certain enzymes to be involved to help with the absorption of B12. And so sometimes you'll give pancreatic enzyme replacement and see if that improves. And then sometimes you could be bacterial overgrowth. So bacterial overgrowth, that can also lead to abnormalities in B12 absorption. So we'll give them antibiotics and then see if it changes. But we don't do that test anymore. We actually kind of make it simplified now, where we just want to know, is it pernicious anemia or not? And so we just check antibodies. And so we'll check the anti-intrinsic factor, the anti-parietal cell antibodies, and see if those come back positive. If they do, it's likely pernicious anemia. If they come back negative, it's probably something else. And then you have to kind of dig into their history a little bit. Do they have gastritis? Do they have gastrectomy? Do they have some type of like bypass surgery? Go a little bit further. Do they have underlying history of Crohn's disease or a malabsorptive disorder like exocrine pancreatic insufficiency or bacterial overgrowth, etc.? You just may have to dig a little bit more. But oftentimes we just check the anti-intrinsic factor and the anti-parietal cell antibodies, see if there's a positive. If they are, it's probably pernicious. If it's negative, it's something else that you have to dig a little bit more for.
Let's say in this patient, we do those antibodies and we find that, yes, those are present and pernicious anemia is the identified cause.
Okay.
How would you treat that? How would you treat pernicious anemia? Is there any steps you would take to really help this patient out?
Yeah, so pernicious anemia, you can give them oral B12, but the problem is that, again, you got to think about it. They're generating autoantibodies against their antiparietal. The antiparietal cell antibodies are anti-intrinsic factor. So the parietal cells make intrinsic factor. Intrinsic factor then binds to B12. It gets traveled throughout the small intestine and then gets absorbed at the ileum. So if a patient has these antibodies, they're going to continue, and you continue to consume oral B12, that B12 is just not going to get absorbed. So bypass the gut and do IM B12. So intramuscular B12 would be the way to go, and I would do that probably for a couple weeks, maybe 4 weeks or something like that, especially with neurological symptoms. And then after that, I would probably do it like maybe going forward, like maybe once a week. And then you can kind of just go from there. But that's oftentimes how we usually do that, is if a patient has a problem where they're not absorbing the B12, it's a significant malabsorptive issue, bypass the gut and just go straight to IM. And you can probably do that like weekly injections. But if it's like a mild anemia, they don't have any neurological symptoms, they don't have an absorptive issue, it's a poor intake, it's a demand, or their malabsorption isn't super bad, I would just give them oral B12 and just keep monitoring. The way that I would like to monitor to know if it's actually working is check their B12 level. But another thing that we could also do is check their reticulocyte count. Because if you looked before, I think in the labs, the reticulocyte index was low.
Yep.
If you start to give them B12, technically their bone marrow should start working and pumping out good reticulocytes. And so the reticulocyte count should start to actually increase, and their MCV should start to normalize. So that's also something I would do, is I would definitely trend their B12 levels, but I'll also check CBCs and a retic index to make sure that their anemia is improving, their MCV is starting to come down, and their reticulocyte index is actually starting to go up. That's kind of how I would do that one.
All right, case one's done. Let's move into case two. We have a 28-year-old pregnant female. She's presenting with fatigue and generalized weakness. A little bit more about the patient. She's currently in her second trimester, she's reporting feeling increasingly tired over the last few weeks, which she initially attributed to her pregnancy. She also describes occasional dizziness and mild difficulty concentrating. She has a history of Crohn's disease, which has been poorly controlled in recent months and admits to a poor dietary intake due to nausea and abdominal cramping. She denies any numbness, tingling, difficulty walking, but is concerned about her energy levels and how she might care for her children. For her physical exam, her vitals, BP is 120/70, heart rate is 85, respiration 16, temp 36.6 Celsius. For her skin, she has pale mucous membranes, dry skin noted on the extremities. The abdominal exam, mild tenderness in the lower quadrants without any rebound or guarding. For her neuro exam, normal sensation, strength, and reflexes. For her lab findings, hemoglobin is 8.5, MCV is 112, the reticulocyte index is less than 2%, peripheral blood smear, hypersegmented neutrophils, folate level is low, methylmalonic acid, normal, homocysteine, elevated. So let's start with some questions about this discussion. And the first one I'm having right away, Zach, is that folate level.
Yep.
Talk a little bit about that and why it can be so crucial to note a low folate level.
Yeah, so when we talk about this patient here, again, same kind of concept. They exhibit anemia based on the hemoglobin. They have an MCV that suggests macrocytic anemia. Peripheral blood smear shows hypersegmented neutrophils. So it's megaloblastic. You're between B12 and folate deficiency. Get the folate level, right? That's going to be one of the things that you have to remember. Folate levels are good, but sometimes they can be skewed by other factors. So just a little kind of like clinical pearl for those of you out there who are practicing. There's actually another test that you can order that's a little bit more effective and it's not skewed by alternative things. And that's a red blood cell folate level. So that's actually one that I like to get. So sometimes if your folate level doesn't really seem suggestive or you don't really, it's kind of normal, but you have a strong suspicion of it, get the red blood cell folate level. But to add on to this, what you were saying is the methylmalonic acid, it's normal. So for B12, it was elevated. For this one, it's normal. So that also helps me in suggesting that this is a folate deficiency. But again, usually with the MMA and the homocysteine levels, I get those whenever a patient has a folate level that's kind of normal, but it's on the borderline limit of normal. In this case, the folate's low. Boom, I got my diagnosis.
What complications could exist with low folate levels? Let's say these folate levels are not corrected and she gives birth. What type of complications and severe complications are we talking about?
Yeah, so folate's really, really needed for closure of the anterior and posterior neuropore for the neural tubes. And so if you have a significant enough folate deficiency, you'll have delayed closure of those. And so neural tube defects can look a bunch of different ways. The most severe, the one that's probably not compatible with life, is anencephaly, where I'm not even kidding, they're like missing like the top half of their head. The other one is it doesn't close like parts of the around the spinal cord area, and so whenever they're supposed to close, you have like these like little sacs on the lower part of the back, and so sometimes this can cause spina bifida occulta. Sometimes you can even have what's called meningomyelocele too, where you have like the meninges and some of the actual parts of the spinal cord bulbing out into that little defect. So these are really, really concerning findings. And so if a patient's pregnant and they have a folate deficiency, sometimes as they get closer to when the actual neural tube is supposed to be developing, you can check AFP levels or maternal serum alpha fetal protein levels. And if those are elevated, it could be concerning for potentially a neural tube defect, but you probably have to get an ultrasound of the mother to get a little bit of a better look, especially of that spine region, to see if there is any concerns for neural tube defects. But that's the really, really important thing that you don't want to have happen.
Now, folate is super easy to get in our diet. It's everywhere. If you eat a normal diet, you're gonna intake folate.
Yep.
In this case, the patient has Crohn's disease.
Yeah.
How would that affect it?
So funny enough, so there was studies that were done where they compared like IM and IV folate to oral folate. No difference. Even if you have like a malabsorptive disorder to a degree, you could still give them oral folate. So most patients, you're going to try and give them oral folate and really bump up that dose if they need it, but then try to increase the folate in their diet with specific food groups. The biggest thing though for this patient is, they do have Crohn's. And so I would say if I'm doing oral folate and I'm really trying to encourage the good diet rich in folate and they're still not improving, that's when I may reach for them to get the IM.
Okay.
But definitely that's the big thing. And then if I also am concerned about a mother having folate deficiency and the baby is in utero, I might give them IM folate to really bump that up because I don't want them to have neural tube defects. So depending upon the severity of the folate and the clinical scenario, it determines which one would warrant parenteral or IM IV versus PO. But most of the time, PO is the way to go.
That's awesome. I didn't know that. Speaking of Crohn's, I just thought maybe it was more of a malabsorptive problem.
Yeah.
They just can't take any oral in.
Exactly. You would think that. And that's the case for B12 deficiency. But I guess from the studies, they found that not so much with oral, that you can just continue to give oral despite the malabsorption.
It's pretty cool.
Yeah.
Once supplementation begins, how would you monitor the response to treatment and assess whether it's improving or not?
I would do the same thing I did for the B12. So I would just monitor their folate levels. Or red blood cell folate levels if I want that for more accuracy. But I would also keep an eye on their MCV, keep an eye on their hemoglobin, and keep an eye on their retic count. So if you look at this patient, do we have a retic index? We do, less than 2%. Mm-hmm. So I would watch their MCV, their hemoglobin, their retic index as I treat them with folate, and I want to see that hemoglobin go up, the MCV come down, the retic index go up, and the folate level hopefully start to normalize. So that's kind of how I would monitor them for that one.
And administering folate, pretty much getting it to a normal level will pretty much restore all those labs to normal?
It should, Yep. And the benefit of this one is that, again, you'll restore the labs. That's why it's really important that if you have a patient who has neurological symptoms, you don't just empirically give them folate without treating the B12 deficiency, because you'll improve their anemia, but the neurological symptoms will kind of just get worse and worse and worse.
And you'll mask it, like you said before.
Yeah, exactly.
All right. Interesting enough. Cool. Well, in this case, then we're going to give this patient folate and then should improve.
Should be good.
Okay. All right. Well, there's case 2. Let's move right into case 3 then. Case 3, and this is our last case. We have a 45-year-old male, presents with fatigue, intermittent nausea, and weight loss. The patient reports feeling increasingly tired and weak over the past 3 months with difficulty performing physical labor at his job. He also describes episodes of nausea, decreased appetite, and a 10-pound unintentional weight loss. He admits to consuming alcohol daily, approximately 8 to 10 beers per day. Whoa!
I know.
8 to 10. Oh, hold on, I'm not done. 8 to 10 beers per day for over a decade.
I hope those are like 40s.
Oh my gosh, he's straight boozing every single day.
That's rough.
And we're not talking a few months here. We're talking a decade.
Yeah, it's freck that liver.
That liver must be just screaming.
Yeah, I know.
The patient denies numbness, tingling, or difficulty walking. However, he mentions occasional abdominal discomfort and yellowing of his eyes. I wonder why.
That liver's frecked.
Yeah, that's crazy. I wonder what's going on here.
Yeah.
He denies a history of hematemesis or melena. For his physical exam, we have vitals: BP 135 over 85, heart rate 78, respirations are 18, and his temp is 37 Celsius. Skin, mild jaundice, spider angioma on his chest and upper arms. His abdomen, mild hepatomegaly, liver span of 15 centimeters, non-tender. Neurologic, normal reflexes, strength, and sensation. For his lab findings, we get back the following. Hemoglobin is 10, MCV is 105, reticulocyte index is less than 2%, peripheral blood smear, there is no hypersegmented neutrophils, vitamin B12 and folate are normal, and we get an LFT panel, and we have an elevated AST and ALT. However, we do note that we have an AST to ALT ratio greater than 2. Going back to that, Zach, I know we've talked about this in the past, but the AST-ALT ratio, what does that mean, and how can it kind of flip in both directions?
Yeah, it's interesting because when you look at the text, like the textbooks, they always say it's like pathognomonic per se, like, oh, if you see that AST-ALT ratio greater than 2, you should definitely be thinking about, it's highly suggestive of alcohol abuse. And it's kind of interesting. I think if you look back at kind of how alcohol works, it has more of a profound effect on the mitochondria in the liver. And AST is going to be more concentrated in the mitochondria and in the cytoplasm. ALT, you don't really find that in the mitochondria. It's just the cytoplasm of the hepatocytes. And so if alcohol toxicity has more of an effect on the mitochondria, you're going to see more of a bump in the AST, and you'll see less of an effect on the ALT. The other thing is that as this patient, they're just chugging along the beers. They're probably developing cirrhosis. And so based on that fact, as the patient develops cirrhosis, the ALT levels actually start to go down. And so if you think about it, mitochondrial toxicity, more AST is going to be leaked from the hepatocyte. And then cirrhosis, ALT level synthesis goes down. So that kind of pushes the AST up and brings the ALT down. And that's how you get that ratio generally. So that's kind of how we would look at that. But definitely in this patient, and I think from when I was learning in school and stuff, when I was on my rotations, one of the things that was always told is a patient who has macrocytosis with even a normal hemoglobin, you should always have a high suspicion of alcohol abuse. And it's a very, very common cause. So sometimes you can get just the MCV that's large, it's greater than 100, but their hemoglobin is stone cold normal. So isolated macrocytosis should be very, very concerning for alcohol abuse and another rare disorder called MDS, myelodysplastic syndrome. But definitely think about alcohol abuse.
So for this peripheral blood smear, it differs from the previous two, meaning that we have no hypersegmented neutrophils.
Yep.
So would that then say, okay, we're talking about megaloblastic or non-megaloblastic with no hypersegmented neutrophils, it's more so non-megaloblastic?
Yep, exactly. Yeah.
All right.
So then we take folate and we take B12 deficiency off the table.
Okay. All right. So then, being that we now have a pretty good idea of non-megaloblastic macrocytic anemia, can you walk us through the diagnostic approach, and then what's the big suspicion of alcohol use as the etiology?
Yeah. So I think when you have a patient here at this point, you got a couple differentials. Reticulocytosis is one, and that's basically when you're pumping out, your bone marrow is working really hard. So if a patient has like a common like hemolytic anemia, it can also cause this, funny enough. But I think the big ones is cirrhosis, which just kind of goes hand in hand with like alcohol abuse, funny enough. Hypothyroidism can actually cause macrocytosis as well. And then myelodysplastic syndrome. So oftentimes with these potential scenarios here, the history is of utmost priority and paramount to the diagnosis. So looking at this patient having overt alcohol abuse, I don't see the need to go further and test for myelodysplastic syndrome and test for hypothyroidism, but I sure as heck could. I could test their TSH and T3, T4 levels. I don't have a high concern for myelodysplastic syndrome because I'd really have to do like a bone marrow aspiration to really get a little bit more information on that. I'm not going to do that to this patient right now.
At this point, his history is telling you, like you said, you have all the information you need. It's pretty obvious at this point. This is a pretty bad alcohol abuse.
Yeah. And so this honestly could go hand in hand. So patients with alcohol abuse and cirrhosis can kind of be very, very intermingled here. Hard to say if the patient has like full-blown cirrhosis. I'd say that there's a strong possibility, but I'd say that alcohol abuse / cirrhosis is the likely etiology in this patient. But if I really wanted to, I could go a little bit further and test the TSH, T4 levels. Reticulocytosis. Remember I told you? Mm-hmm. If it was reticulocytosis, the retic count would be high.
Right, and it's less than 2%.
Yeah, so it kind of rules out the reticulocytosis as well. So with that being said, if I really wanted to, I could work them up for MDS, which we'll talk about in another podcast. Or I could work them up for like hypothyroidism, check some TSH and T4 levels and see if that comes back abnormal. But otherwise, I'd say that this is probably alcohol abuse in this scenario.
What specific interventions would you recommend to address the anemia and the underlying cause in this patient? And then a little bit further then is, let's say they do have cirrhosis. What would you do for this patient? Yeah,
so in this scenario, I would just do my best to promote alcohol abstinence, right? That's really the key thing. If you remove alcohol from the patient, funny enough, the MCV will start to normalize. The hemoglobin will start to improve. If they have cirrhosis, it's a little bit more difficult. So that might not be something I can easily fix because the damage has already kind of been done to a significant degree.
Right.
But oftentimes it kind of goes hand in hand with the alcohol abuse. So alcohol abstinence is going to be the most important thing.
Okay.
Regarding if the patient does have cirrhosis, there's only so much I am limited to do. Obviously, trying to reverse the underlying cause is key. But treating complications is really where it comes down to. So I'd say this is a patient with compensated cirrhosis if they did. So they don't have any like evidence of ascites or spontaneous bacterial peritonitis or hepatic encephalopathy or, upper GI bleed with like hematemesis because they didn't have any of that. So I don't see any evidence of like a decompensated state. And if they did, I would treat those accordingly. So if they had like ascites, I would try to treat the ascites. If they had a bleeding from a varices, I would treat that accordingly. If they had some type of SBP or HRS or etc., I would treat those things. But in this scenario, this is a compensated cirrhotic patient. So unless complications arise, nothing much I'll do. I'll keep a close eye on them if they start to get really, really bad and they develop decompensated cirrhosis, treat those things, and then talk to the transplant team about it, considering them a transplant. But
I was just going to say, at this point, you can only treat so much that you can. The damage is done. We're talking transplant.
Yeah, and hopefully they would even be a candidate given their history here. It would probably be tough to talk a transplant team into doing something like that.
True.
Yeah, but
all right.
That's kind of how I would go about this one, and then just hope and pray that they would remain abstinent to alcohol and hopefully see some improvement over time.
Well, sounds like we've got a pretty good idea on case 3, and that's macrocytic anemia.
Yeah, that wasn't too bad of a one. I think oftentimes this is like one of the easy ones. If you get any questions on the exam, you're like, please, for the love of goodness, give me this one because it's a simple one.
Don't give me normocytic anemia.
Yeah. Don't, please. I'll get it wrong. I'll take the L. But yeah. I think that this is a pretty good podcast because I think you get straight to the point of like what we need to know regarding if you get that anemia and you find out that it's macrocytic, what are the steps that I need to take? That's what I hope that you guys were able to gain from this podcast. But I had fun. Did you?
Had a lot of fun.
Got to use those tools when we can.
All right, that was too much. Too much applause. No, that was really, really fun.
Yeah.
I liked it. It seemed like a little bit more straightforward approaches as compared to normocytic.
Yeah, that was.
But again, that one was a beast. But that's it. That was all of our anemias from micro to normo to macro.
Yeah. So thank you guys so much for sticking in with this podcast. I hope that you guys learned a lot. I hope that you guys really did enjoy it and hope it makes sense. Continue to support us. You can do that by hitting the like button, comment down in the comment section, subscribe, download these podcasts if you guys need to. But also don't hesitate to go to our website. We have a lot of cool resources that I think will really help you in your learning process. But thanks so much for sticking around. Love you guys. Thank you guys. And as always, until next time.